She's all ready to go. Okay. Good evening, everyone. It is 4:31. I'm going to go ahead and call the meeting to order of the Board of Managers Workshop. It's Wednesday, March 27th, 2019. Again, it is 4:32. Before I put the first item on the floor, I want to announce that this workshop will end at 5:20, so that the broadcast of the Board of Managers regular meeting can begin at 5:30. So we are a little time crunch. Agenda item 1: receive and discuss a presentation on legislative filed during the 86th Texas Legislative Session that allows Central Health to create a local provider participation program and accompanying fund in Travis County. And with that, I'm going to ask Mr. Giesland.
Yes, thank you. Members, thank you all for your time today and attending this special call meeting, which functions as a workshop to talk about the LPPF, which is a local provider participation fund program that is another way to pull down supplemental funds under the Medicaid program to ultimately fund health care for the low income and the uninsured. Today, Jeff and Monica will be presenting, and again, this is a workshop to talk specifically about the legislation. A couple of you have asked us about our own internal processes around the legislative session, and I'll be addressing that in the CEO's report this evening in the regular scheduled board meeting. With that, I'll turn it over to Jeff or Monica.
Thank you. Jeff Knoebel and Monica Crowley will be making the presentation. I'll get it kicked off and let's get started. So this presentation is about, as Mr. Giesland mentioned, the local provider participation funds. This slide shows the specific bills related to the creation of the LPPF. Senate Bill 1350, sponsored by Senator Watson, House Bill 3649 by Representative Hinojosa, and specifically gives the Travis County Health Care District the authority to create and administer the LPPF, and the administering role, as you'll see, is important and is actually a role in the structure. So what is an LPPF? It's a method of financing that has been approved by CMS that allows private hospitals to access federal Medicaid supplemental programs, payments. Basically what that means is it allows private hospitals to make payment into the LPPF to be used as a local share to participate in those in the Medicaid supplemental payment programs. All inpatient hospitals in the LPPF jurisdiction pay a uniform mandatory payment into the fund. And we have a subsequent slide coming up that shows a more graphical representation of the structure of this. So just bear with me as we kind of go through some of the requirements. The payment made into the LPPF is typically a uniform percentage of hospital net patient revenue. So these are private hospitals that participate in the LPPF, and they make a payment into the LPPF to the administrator of the fund. And again, we'll have a graphic of that. But overall, that rate cannot exceed 6% of the hospital net patient revenue. And then the LPPF administrator transfers these funds, and again, these are considered public funds, to HHSC, Health and Human Services Commission, or the state, who's IGT, on behalf of the paying providers. And then those funds are typically sent up and matched at a federal rate. Those dollars that are paid into the LPPF are segregated They are held in a fiduciary responsibility by the administrator. Local taxpayer dollars that we typically receive are also segregated, and they are not commingled with LPPF funds. So specifically on a LPPF, as I mentioned, there's an administrator. In this proposed legislation, Central Health would be the administrator. And as that administrator, there's some roles that the board of managers would serve related to that function. And so you see that listed here. The board authorizes the district to actually create the LPPF with a majority vote. And then there are some rules that are adopted around administration of the program, collection of payments, expenditures, audits, et cetera, It also can require financial and utilization data reporting from participating hospitals. And then for each year, the board authorizes participation, including the initial year, there's a public hearing. So there's a, I believe if I remember right, there's a prescribed notice period, public notice, there's a prescribed period, and then there's a public hearing prior to both the creation of an LPPF, and then there's a public hearing each subsequent year related to the LPPF. And as I mentioned before, the administrator role is what I would call more of a fiduciary role, but there's a separate bank account maintained specifically for those LPPF funds that the administrator maintains in that capacity. So what are some of the uses? So as an administrator, payments from private hospitals are flowing into the administrator. What are some of the uses of the LPPF? Funding intergovernmental transfers, or what we call as an acronym, IGTs, for uncompensated care, a program that the acronym is called URUP, which is it stands for Medicaid Uniform Rate Enhancement. And again, these are for non-public hospitals. Payments available under another waiver that are similar to the current waiver, the current 1115 waiver. And then any reimbursement to non-public hospitals for which federal matching funds are available, including disproportionate share. Currently, DSRIP is excluded from these bills. And then as the administrator, there are certain administrative costs associated with performing the administrative roles. And there are a number of bills you'll see that we will show in a later slide that have been proposed. The administrative expenses that we've proposed in this bill would be up to $150,000 per year, and then that would be in addition to the cost of collateralization of the deposits. And so that's simply a banking term for there's a cost to maintain securities, physical financial securities to collateralize the amount of cash that's in the account, and there is typically a cost associated with that. So that would be passed on also and paid for through these hospital payments. And then we've shown this slide in a previous board meeting, or budget finance, I believe. So sorry, that did get confusing. But I want to reference you a little bit. So this is the more comprehensive slide that we prepared for that presentation. But I want to take you back a little bit. When we did our initial presentation, we talked about two things. We talked about uncompensated care and some changes to uncompensated care that were going to occur beginning October 1. And then the second part of the presentation was about the LPPS. And so this particular slide is kind of the comprehensive slide of both what an LPPF looks like and the changes that are going to occur in uncompensated care beginning October 1 of 2019. So the slide itself shows the current IGT process. And as an example for uncompensated care, up at the top, the IGT entity of local funds.
Hey, Jeff. I'm sorry.
Mr. Giesman.
I'm sorry to interrupt. If that pointer is up
Yes.
there, the red one, just to kind of orient us towards
Okay.
it. You can point to the back slide over here if you're
I want to
visually having a hard time orienting towards where he is on the slide.
Better to point.
There you go. It's the green dot. Thank you, Mr.
So
Chairman.
currently, it's not gonna show up, I'm missing.
That's a mouse.
Yeah, this is, I don't think it's just because this is glass, it doesn't. Yeah, okay, let me point at this one here, so we can see it here. So typically, on the top here, this is currently how, for example, uncompensated care would work. So Central Health would be the IGT entity and would send local funds up to receive federal match. And then that local and the federal funds that would be received would be directed to a specific hospital. Okay, so we do it facility specific in the current structure that we have today. So there are two pieces of this bottom here. One piece is the actual LPPF structure, and then the second part of this diagram are the changes related to uncompensated care. So the left-hand piece right here that I'm circling is the LPPF structure. And so to the left here are the private hospitals that are making payments. And again, remember, this is typically it's a uniform payment. That's a percentage of hospital net patient revenues that are paid to the administrator of the LPPF. And so in this diagram, this light purple box here would be Central Health as the administrator. So these uniform payments are made to the administrator of the LPPF, and the administrator would send those local funds up for federal match. So now you have the local and the federal share. And so I'm going to pause here for a second because that's the LPPF structure. I just don't want there to be confusion. Oops. I'll try to confuse everybody, but so the right-hand part are the changes that are being made in uncompensated care, and we selected this as an example of how uncompensated care is proposed to work beginning, or will work beginning October 1. So those local and federal funds are now put into a pool, the Medicaid service delivery area, which for our area is 8 counties. And then those funds are distributed across all the hospitals in that 8-county region, pro rata based on uncompensated care costs by hospital. So the part on the right here is more specifically related to uncompensated care, but we wanted to show kind of an end-to-end result of how all of this worked. So what we're talking about today, specifically around the LPPF, is this part on the left-hand side, which are the private hospital payments to the administrator. Again, the process would work the same as it does now, which the local funds are sent up for federal match. It's just the LPPF is administrators doing that on behalf of all of the hospitals that are participating in the LPPF. And the requirements for participating in the LPPF would be all private hospitals in Travis County, all inpatient private hospitals in Travis County. I'm gonna turn it over to Monica,
And
the second half of the.
I'm gonna actually skip that slide and then come back to it, because this slide shows, and you guys have seen this before, the LPPFs that currently are in Texas, and currently there are about 20, and there are LPPFs in the Dallas County Hospital District with Parkland, the Tarrant County Hospital District, which operates JPS, and the Amarillo Hospital District, and then Beaumont as a city is an administrator of an LPPF, and then there are also LPPFs administered by counties, primarily in East Texas and then along the border. And so there are 20 that are currently in place. There are over a dozen bills that have just been filed in this legislative session alone. So there's a lot of interest in LPPFs during this current legislative session. And this includes bills to continue the LPPFs that are currently in place in Tarrant and Dallas, the Tarrant County and Dallas County Hospital districts. And then also in the other 4 major urban hospital districts, and then 5 new bills in rural counties, and then also 2 new omnibus LPPFs that are also being considered. So, you know, we're not the only hospital district or kind of public entity that's interested in this structure during this legislative session. And then we're really looking at why particularly are we looking at an LPPF in Central Health with the private hospitals in Travis County. And, you know, for us, our greatest concern is that this allows greater flexibility to continue to access federal dollars to help supplement uncompensated care, given the coming changes to these rules that will go into effect on October 1st that Jeff was just demonstrating in the previous slide. And another one is that this does comply with a CMS approved way for private hospitals to use their funds to provide the local share that allows us to continue to access these Medicaid supplemental payments from the federal government. And for us, it's that additional local tax dollars aren't required for this. Like Jeff said, our local tax dollars can't be commingled into the LPPF, so this is a way for given the UC changes, for the private hospitals to provide that local share so that we don't have Travis County taxpayer dollars being diluted across this 8-county region, but we're still able to access these important supplemental funds that are, you know, essential to support the uncompensated care that many of the hospitals are provided. And so here's what the status is. House Bill 3649 and Senate Bill 1350 have both been filed and were referred. On March 21st, at the House side, a hearing was heard in House County Affairs, and we left the House bill pending while the Travis County, the hospital leaders of the private hospitals in Travis County and Central Health worked to fine-tune the legislation. And then on the Senate side, this bill hasn't been set for a hearing yet.
And then I would add that we were over at the Travis County Commissioners Court yesterday, did a brief presentation on it, and there was a vote to support our legislation around these bills.
Yeah, I'd like to limit discussion to about 29 minutes, if we have a time constraint. The vice chair asked first.
Two very quick questions. If we go back to the chart that you had up there, first question, are all of the private hospitals required to participate? Is that as in, it's mandatory?
That's correct.
Okay,
It's
so
mandatory.
all the private hospitals in 8 counties must participate?
Well,
Yeah.
so the LPPF is county-wide.
Okay,
So for our LPPF in Travis County, it would be all Travis County
Okay.
private hospitals.
that's what I thought, but it wasn't real clear when you started talking about 8 counties. So all private hospitals in Travis County must participate. And if new private hospitals were to enter Travis County, then they would have to participate?
That's correct.
Okay. And the maximum amount of funds that each hospital could put in is 6% of their revenues? Is that
Net,
what you?
net patient revenues.
Of their net revenues, not
Yes.
gross, their net revenues.
That's correct.
Net of expenses. What is the relationship between what they put in? Let's say that each of them put in 6% of net revenues. But what I heard you say on the right-hand side from where I'm looking is what they get back is not according to whether they put in 4% of their net revenues or 3 or 6. It's according to their share of uncompensated care.
That's
Is that correct? Okay.
Right.
Right. Just want to make sure, do we know in these the other ones that have been established, the other LPPFs, what the relationship has been, between a particular hospital's input and its compensation on the uncompensated care?
They're all, so from an LPPF perspective, they're all required to collect a uniform rate of, let's say, net patient revenues. So the actual collection is set, generally
So
let
who
me-
sets that rate? 4%, 3%, 6%?
the board would set
It would,
that right. So
okay.
generally speaking, my understanding of how this would work is, we as the administrator would work with the hospitals
Come to a
come to a
consensus.
consensus and agreement of the rate.
Okay,
We would propose that rate to the board. The board would have the final approval related to the rate setting process.
okay.
And that, I'm gonna assume, would occur minimally on an annual basis.
Right.
There may be some situations where you may have to come back for,
Okay,
another rate adjustment,
okay,
depending on circumstances.
okay. All right, thank you. Just-
You answered. You asked one of my questions. Thank you.
You're welcome.
Andrew Oliver?
So, is there currently an LPPF in Travis County? Not obviously Central Health, but I thought there was,
No.
the hospitals never formed one.
There-
Because when I was leaving St. David's, they were,
Hayes and Williamson, but there is not currently an LPPF.
when I was leaving
Travis County.
St. David's over a year ago, they were contemplating one for Travis County, but without Central Health. So I wasn't sure if that ever got off the ground without Central Health. Without Central Health.
No, well, that has to, one
have to
of
have
the reasons here, there has to be
Okay.
legislation.
Okay, so am I right, or in reading it said it, hang on, the only organizations that can be in this are private hospitals?
Yes, and it's based on IRS rules, and so the definition of a private hospital that they use, it's any hospital that is inpatient hospital, and it's not owned or operated by a public entity.
So my question is this, on SB 2112, which Kirk Watson filed 20 days ago, it would allow the classification of a public hospital for anybody that Central Health contracts with?
That doesn't change.
Does that affect this?
No.
So Seton would still be considered a private hospital and would have to pay in?
Under the IRS rules, they have to be, the LPPFs have to be uniform, so as Jeff said, there has to be a single mandatory rate that's levied across all the private hospitals, and they have to be broad-based, and broad-based means that every private hospital under the federal IRS definition has to participate, and that IRS definition of private hospital is not owned, or the definition of public hospital is owned and operated by a public entity. And so any hospital that is not owned or operated by a public entity in Travis County would have to participate.
So this potential bill actually says that the commissioner would adopt reasonable rules determining governing the determination and payment of supplemental reimbursement to which hospitals would be entitled to under Europe or, I think, waiver.
So
And they would be deemed a public hospital is what it says.
So
with respect to-
under TAC, there are definitions of public hospitals for what they receive in uncompensated care, and that's very specific, related to if you're a member of the transferring coalition, paying up into DISH, what hospital receives the hold harmless for uncompensated care purposes. And there is an open question at HHSC as to whether a hospital could be both on the federal level, because the
right.
supremacy clause is still in place. I mean, so no matter what the commissioner does on the Texas side, not changing, hundreds of years of
Federal law supersedes.
I
federal
just
law.
wasn't sure under the
But
LPF,
there's a
LPPF
question,
statute.
yeah, and the
If it would be deemed.
LPPF has to comply with the federal laws. And that's one of the things, it's even in the LPPF legislation that says this complies with all state and federal laws. It has to, there's an open question as to whether you could be both a private hospital paying into the LPPF and then also counted as a public hospital just for the hold harmless on the UC, the UCHSL DISH receipt question.
Got it.
Yeah. Thank you. Sorry.
And
No, that was a really good question.
Entire Texas Administrative Code.
Texas Administrative Code,
Any
sorry.
questions?
Yeah, I'm good.
Andrew, was that the?
Oh, thank you. Jeff and Monica, appreciate it. So I just want to make sure that we all understood, just follow me through steps here. So right now, we can no longer IGT.
No.
So I think you're asking what's the impetus for this legislation? Is there something else happening
Yes.
that is resulting in us wanting to pass this legislation?
Go ahead.
Well, it's not that we can no longer IGT, it's that under the new uncompensated care structure, if we were to continue to send up local tax dollars the way that we historically have for uncompensated care, instead of it being directed to the hospitals that provide services primarily to our population in Travis County, it would be diluted across this 8-county region, and that is something that we would prefer to avoid.
Okay, no, I understood. So right now, if this legislation passes and Central Health would become the administrator, so would we have more control over our patients' data and outcomes? So would that be an administrator role that we will carry on? And if certain hospitals are not meeting good outcomes, is there an accountability to how much they get reimbursed? Or regardless if they're seeing our patients and regardless of the outcomes, and they're putting in money into this, they will still be reimbursed. So just trying to understand.
It's a very uniform process.
Right.
So the mechanics of it are very straightforward, that X amount of dollars are put into the LPPF and then they're transferred for specific programs. I think the only constraint you may have would be if there's not enough money in the LPPF, you would send up what available resources were in the LPPF. But as far as roles that you're mentioning, that would not be current roles of the administrator
Now, there could
to
be
make
other,
those, to make those type of decisions.
tied to the LPPF, there can be other continuing contractual arrangements with the hospitals that we work with that continue in place that are separate from Central Health's role as the administrator of the LPPF. The data that's contemplated as being reported to the Central Health Board as the administrator of the LPPF is currently in the legislation. It's reports that are sent to the Department of State Health Services. Other LPPFs also are proposing Medicare cost report information that would be reported to the administrator of the LPPF, but it's not kind of outcomes based reporting. It's more cost reporting.
Okay, thank you.
Can I just want to add on to the previous question you had. You were asking about why. So I think Monica went through the uncompensated care piece. There's also other programs that could be participated in that we currently don't participate in. For example, Europe, which is the Uniform Hospital rate increase payment. Yeah, sorry, I knew it was something simple, so I couldn't remember it. But it would allow, we currently don't have, we Central Health in the current structure, we don't have the capacity to participate in that program. But the LPPF could be a structure or a mechanism for the hospitals to put funding in the LPPF to participate in that program. And that's a rate enhancer, payment enhancer on the Medicaid side, similar to a portion of what disproportionate share funding is.
So one last question. Are all the private hospitals within Travis County aware of this potential changes? Are we in communication with them?
Yeah.
Yes, I'm surmising most, if not all of them, are aware. We have several representatives from some of the hospitals. I just don't know if there are any small hospitals that haven't been reached out to yet. I think we need to do some more follow-up on that.
Okay, thank you.
Thank you.
Angela Valdez.
Hi, thank you very much for the report. And first and foremost, the one thing I'd like for you to provide to us, if at all possible, is the language that exists in, like, say, state statute or federal statute or rules from the HHSC that would talk specifically about what you referred to as here, I guess the citations of what may or may not be covered by definition. And you were talking about, oh, well, because of this at the federal level, then that, and then with respect to programming, well, if we do this, and you might be able to do this under a different program as opposed to this program. So those kinds of things, so that we can have a roadmap as to what pieces of legislation and what language is covered or not covered or excluded or included by the different existing rules or ordinances or laws, and currently in the works. So legislatively, if we know that because they've already filed all the bills, so is there additional, are there additional bills that are being filed right now currently that maybe have or have not had hearings that would impact this? I just wonder.
So one of the things I think that you're referring to specifically, and Monica was nodding, so I think she understood as well, was you want the definition of what a private hospital is under
And
the
public.
IRS regulations and what a public hospital is under the IRS regulations.
And the impacts due to existing statute or codes, and proposed that has maybe at the state level not necessarily been enacted upon, hasn't been.
So like the new proposed rules
Right.
around uncompensated care
That's
that
right.
have been published,
right.
but that go into.
But not
effect on-
necessarily
okay.
having been heard or
So
adopted.
more information on what you see on the right-hand side of the chart.
That's exactly right.
Yeah.
Yeah.
Yes. And then,
Can I just add on the program side of it? So I get what you're asking. I just want to make sure that we don't lose sight that this is a collaborative process
Right.
with the hospitals. And so
Oh, yeah.
you size up, I mean, the way I would envision this working is there's discussions on the programs that would be participated in, and then there's a adequate sizing of the local share to participate in those programs. So I just wanted to mention again that it's more of a collaborative process
That's right.
that, you know, eventually would come to this board,
Yes.
and then again, the board would perform
And
its
that's one of the
role as
reasons that I'm asking the
administrator.
question, because collaboratively speaking, as we all work together to achieve similar goals, or the same goals, or the highest level of quality type goals with the most outcomes, this would be maybe another tool that we had to be able to accomplish that. So that's why I asked for that. Thank you very much. And on page, oh, that's not a page, it's the one that's fund uses authorized in SB 1350 and then HB 3649, that page? Yes, that one. When, again, I think this may be what Julie asked, but I'm not sure. Reimbursement to non-public hospitals. And these are currently excluded from SB 1350 and 3649. Currently excluded. So does that mean that if this passes, legislation passes, they will be included?
No, if the
Legislature.
legislation passes,
Yes.
it's that the hospitals, what we had said at the end is that the hospitals are still talking, there are probably going to be there are almost certainly gonna be amendments to the legislation as currently drafted as the hospitals, continue to work together on refining what the legislation's going to look like.
Right.
And, we don't know exactly what the final version
Outcome
is
will be.
going to look like today.
Right, no, I know,
Right.
but pending, assuming that there are minor tweaks and that legislation is approved, and it'll be in effect starting September 1st of 2019, which is this year, and it is going to impact our budget. I just want to make sure that we know that so that we can take all those things into consideration.
And we do have to remember that this is also something that it's not, so there is an impact on our budget. There will be some administrative expenses that we can reimburse, but that this is a fund that is created through a levy upon the private hospitals. And it does not include our tax dollars that our local taxpayers are providing.
Right.
So, this is something that is, I think the thing that makes this so popular, particularly in Texas, is that these are the private entities coming together and participating in this levy on themselves to help fund the local share and draw down these federal dollars.
So with respect to the omnibus bills on HB 2257 that are not served by a hospital district or a public hospital, are those the ones that we saw that may be city-owned or city-run as opposed to, I'm sorry, where a hospital exists or doesn't exist?
I
What
think
is
these are more uniform structures that allow these entities to establish a LPPF just from it's not a specific county or area.
Region.
It's just across the state, it's a structure. There have been a couple bills that have been filed that would allow, for example, if it was a smaller county,
Right,
in
rural.
West Texas rural that does not have specific legislation, they could actually create an LPPF under this pending legislation.
So when we talk about the bills that have been filed, we have them by numbers, but we really don't know what counties or what areas. Is that what the slide that you all presented to us, is that what this is covering, all these additional LPPF bills that were filed?
No,
during
the
this session?
slide with
Is
the
the ones that
picture of
exist- currently
Texas are
exist.
the ones that currently exist. And this one, the slide has the ones that currently exist. And this one, it listed, yeah.
Right, those exist, and these are the
These are the
current
new
bills.
ones. And I think and this is where I'm gonna Coburn, do you know which
Uh,
5 rural counties?
Monica, I'm
Okay.
gonna limit it
Okay.
7 more minutes, and
Okay.
that's it.
Okay.
But we could get you the
Yeah,
5
if
rural
we can all have a
counties.
copy of that,
Yeah,
that'd be
of course.
great. So, thank you very much. I think that is it, except for one last one on the House County Affairs, when they had the hearing. And it was stated that, while Travis County's hospital leaders and Central Health fine-tune the legislation, what are some of the issues that are being considered that need to be fine-tuned?
So, may I answer that?
Yes.
Given that this is the hospitals that will be paying this, they obviously there's a bulk of the discussion occurs in and around amongst the hospitals on this, and so I'm not going to speak for anyone. Let me just start out by saying
General.
just generally speaking. The bill that's filed right now mirrors what was filed for Parkland, and the idea was get a bill in the hopper so you can have a starting point for some discussions. But I would say some of the issues would be probably around what all is included and not included, what constitutes a public versus a non-public hospital. Those are some of the big ones. Again, I don't want to speak for any of the hospitals, but there could also be some discussions around how this is administrated. To me, it's fairly cut and dry because you adopt rules, and I've done this sort of thing before, but wouldn't surprise me at all if there were questions around
Yeah,
the
we're seeing a
administration of it.
variation on the administrator reimbursements. I think we're on the lower end of it, if not the low end. I don't know, there may be some discussion. I mean, we don't know what all the discussion pieces may be related around that.
If somebody on our team knows, because
Yes, and just to let you know, I am convening a meeting of representatives from the hospitals just to be able to get a better sense of, okay, what are the issues? Where is everybody right now? We don't broker that per se. We might facilitate that meeting because ultimately it's their money. They're going to have to pay that. But I'll have a much better sense, I would say over the next week or so as I understand, what are those outstanding
so
issues.
that opens the door to one more thing. So as there are other districts that have LPPFs in place and have had them for a period of time, I'm assuming, what's the oldest? Do we know? Just, is it,
We can find that information.
okay,
We're
the
really
reason I'm asking that,
And I need to look at my other managers to see if they have
okay,
any questions.
well,
Manager
the
Bell.
only reason, excuse me, the
Hold
only
on,
reason,
Manager Bell doesn't need to go on.
I know,
We're
but the
really
reason I'm
limited.
asking that is because the $150,000 administrative fee is, would that conceivably cover all assumed operations and maintenance costs? Okay,
I've got 5 minutes left, Manager
thank you,
Bell.
yes.
Any questions? Manager Jones, any questions?
I just have a philosophical, a general question. Will this result in addressing or create any undue expectation on Central Health with surrounding counties in terms of its ability to provide care?
Good question, Shannon.
Yeah, no, so one of the things that I think particularly in our SDA, when you look at the most populous counties that also have large hospitals, there's already an LPPF in place in Williamson County, and there's already an LPPF in place in Hayes County. And, they would, we would anticipate, participate as well in sending up IGT for some of these programs. So hopefully, I think it makes the new state structures kind of level out to more of a status quo.
I'm just
Equalize.
concerned about an unexpected or unintended burden that might result on counties, particularly from surrounding counties like Bastrop and Caldwell. So,
I think we always should be mindful
yeah,
about
okay,
that.
that was my question.
Thank you, Manager Jones. Manager Musaitis, if it can be quick because we have to get going.
So this is part of the allocated federal funds of 3.1 billion, correct?
For uncompensated
For uncompensated care.
It's currently 3.1. We don't really know what's going to happen.
So that's
to
the
that.
thing, we don't know about the unknown and if this will be a continuous funding.
Well,
in the
I
future.
think at least what we've seen on the state side is there's at least a placeholder for future years. It's about a 25% reduction
in uncompensated care. That's at least the latest kind of budget neutrality schedule I've seen for the waiver. Again, this is the 5-year period. There may be an update to that. I'm just not aware of it.
Thank you, that's.
Thank you, Manager Greenberg.
From what I'm hearing, this legislation would allow us, meaning Central Health, meaning Travis County and the private hospitals, potentially to bring in dollars that we wouldn't otherwise be able to. Is that correct?
It would allow us to participate in some programs that we currently
Yes.
don't participate in.
And those programs come with dollars, correct?
That's correct.
Thank you.
And they reimburse uncompensated care.
Yes, and they reimburse them.
Or
other-
Medicaid,
Yes,
potential
okay,
Medicaid rates that may not cover cost.
thank you.
Jeff, Monica, thank you so much for doing this so quickly, and
Well done.
Board Manager, I'm sorry.
No, sir.
Managers, thank you for your time constraints. We have to get going because we have to get ready for, we have to allow our media people to get ready for 5:30. Do you have something to say, Mr. Ethan?
No, sir. This one,
I
thanks.
was just gonna ask if this, if we're, if everybody's aligned on their various missions with the various hospitals. They're all aligned to the Central Health Mission with respect to this?
It's uncompensated care.
All right,
Yeah,
It's just their
it's just
uncompensated.
that.
Yeah.
all right. This was an informational item only, no action is necessary. I'm ready to accept a motion to adjourn.
Yeah.
So moved.
Second.
Yes.
All in favor, say aye.
Aye.
All right, thank you all.
Thank you, members.
Thank you, members.